Good afternoon, everyone. Good afternoon. I have been asked to second guess my colleague, Mr. Njuguna. I will try and not do that. Usually they say, if you have two lawyers in your organization and they usually agree on everything that you propose, then you probably don't need one. So in this case, I hope one of us will be needed, or at least both of us will be needed. Anyway, mine is a very brief address to this congregation, and I want to start it by just tracing an old wish I had. Growing up as a child, like many of us, I dreamt of being a doctor. And somehow life hit me and I found myself a lawyer. So somehow I still wanted to end up in a hospital, and I entered it through the back door. And having entered the hospital through the back door, I am the lawyer for Kenyatta National Hospital, which is still a hospital anyway. So I think I achieved my dream in a way. We were doing interviews for medical specialists this morning, and I think my observations were that maybe it's a good thing to be a lawyer who works for a hospital. Then let me not go into that. All right, thank you very much. My name is Nyachoti. My address is basically very simple, to touch on a few areas she might not have touched on, and to give you a few illustrations that arise directly from my experience within the health institutions. I'll start by just mentioning about 3 or 4 cases very briefly. She mentioned a few, one South African and one Kenyan case. Let me trace just about 3 or 4 of those. On my very first day in office, and that was sometime early this year, in February this year, I landed in the office, and the first person who came to see me was a lady who had, through a system of assisted reproduction, got a child through a surrogacy arrangement. So basically, the couple was unable to get children naturally. What they did was to extract the gamete, do a lab fusion, and then implant it into a surrogate mother. The surrogate mother carried the pregnancy for 9 months, came to Kenyatta National Hospital, delivered, and now it was time after 3 days to go home. So when she came in, she did not present an identity card. When she was leaving, she also still did not have an identity card. So when she was asked what name do we fill on the birth notification form, she gave a name. She was told, you need to bring us your registration documents before we can do that. At some point, the nurses noticed something funny. There seemed to be someone else hovering around who seemed to be more interested in the child than the mother herself. And so the nurses asked, and who are you? And she kept on saying, I'm a cousin to this lady, but we need to discharge her today and she needs to go home, and the name you put on the notification is the name I've given you. And that name, incidentally, was later on to be learned that it belonged to the uneasy lady rather than the lady who had delivered the child. So when that information became known to the hospital, the nurses then refused to register that name unknown to them, tells the lady who delivered, according to us, you're the mother. You're the one who delivered. We don't care what you did out there. What we want is to register you as the one who has given birth. And that is our hospital policy. So she then finds her way to my office very early in the morning. And it was my very first day in the office. And here she is presenting that they have refused to register me as the mother of the child. I am actually the genetic parent. But we were trying to pass off the surrogate mother as the genetic parent. Why? Because we live in the UK, and unless this child is registered in my name, I cannot be able to enter into the UK with her. And therefore, she needs to be registered in my name so that I can go home with her and eventually to the country where I stay. Now, unfortunately, the law in Kenya does not tell you what to do in such cases. It is quiet. In fact, there is no law with regard to that. No recorded cases, Not that there have not been cases, I'm saying there are no recorded cases that you can use as precedent, and therefore I found myself in a situation where there wasn't many ways to move forward. So what I did was to go and sit up most of the night doing my research and trying to do a legal opinion to advise the hospital what to do. The following morning I present my opinion to the hospital, and the CEO tells me I'm not ready to make this decision which you're requesting me to make, because it's a policy decision, not just a matter of fiat. So I suggested, then let's write to the AG, let's give a background of our story, let's capture what we want and ask if we can do that. And so I was given the go-ahead to do that. I did an opinion to the AG, I gave all the facts, I gave out our proposition, and in my view, I found nothing wrong with registering this mother as the mother of the child. Why? Because essentially, the DNA of this child who has been born is made up of a fusion of her and her husband. Among other things, they had entered into a contract with this surrogate mother. Although the veracity of that contract can be doubted in court, essentially they had entered into a contract saying, I hereby undertake to carry your child for this period. When I give birth, you take the child, I have nothing to do with it. Here she is today, she is not disputing that. She's saying, yes, I gave birth, but it's not my child, it's her child, and I'm ready to let that child go. So we gave that position, and we requested for the AG to indulge us in going ahead with that. A month later, the AG did, and the parents today, together with the child, are somewhere in the UK, nursing their otherwise 6 to 8 month old. I don't know whether that was a good thing or a bad thing. I leave it to you. Number 2, a few weeks later, again with due respect, and my colleague did mention it, one Audrey Mbugo walks to my office again and presents herself, explains her position, and says she wants Kenyatta to undertake the operation that she requires, a gender reassignment operation. I look at the record and what is in there, and unfortunately there isn't very much to go by. Again, no one has been facilitated under this program before. A few cases exist, but so this one, what do you do where it's an adult who is telling you, my right hand or my left hand is fine, but I want you to cut it off? What do you do as a doctor? You find nothing wrong with that right hand. Do you cut it, or do you tell them, sorry, I won't do that? And so that's what we were grappling with when it comes to Audrey Mbugo. She basically, when I declined officially that we were not going to undertake that, she reported us at the Commission of Administration of Justice, and that matter is still pending there. So I don't know again what will happen or what will come out of it. But you see, ladies and gentlemen, there is simply no time, but the examples can go on, and there are many of them. But what am I trying to bring out in this? The discussion as to the right to health is not a theoretical discussion. These are things that we're actually dealing with, to the extent of some people saying, what is the government doing to be able to realize my own requirements as to health? What steps have you taken to equip the hospital, to hire enough doctors, to be able to create enough room for us to sit there and do this? I've gone to the orthopedic ward in the hospital, and it portrays an example which I thought does not exist anymore, because it's simply overcrowded and people overstay there for no reason, among other things. But again, these are some of the realities that we have to deal with. So what exactly is required within the Bill of Rights regarding the provision of adequate health care? Essentially, it is that the government shall take steps to be able to ensure that every time you need some health services, you are able to access the same. What are these steps that potentially could result in that? She mentioned two. One of them is passing the necessary laws to be able to realize that. Number 2 is adoption of various policies, and then going onto the ground and actually creating the infrastructure and making sure that systems work within these hospitals. How is the government faring on this? Again, I don't know. Regarding to the Constitution, maybe we still need a few more days in order to tell, or the jury is still out on how well this is being implemented. But I guess there are some efforts, there are some strides in the right direction in terms of trying to provide this. But what exactly does this right relate to, and what does it carry? It is basically, don't deny any patient who needs emergency services, and this is services that can either prolong their life or ensure that they don't die, or ensure that their condition does not worsen, and also see to it that the facilities, the kind of treatment, the standard of care is up to the highest guaranteed standards. So indeed, it was always said that the right to life is the first one, then all the other rights are anchored on the right to life. You will actually be surprised that life, if you're not healthy, is probably not a lot to talk about. So we might actually be going a step further and saying probably one of the fundamental requirements for you to live a healthy life, so to speak, is for you in the first place to be healthy. The other day we were talking about disabilities, and various people are saying this is a disability, this is not. Actually, being unhealthy is a disability in itself, and therefore unless you are of good health, you may not be able to exert yourself and be able to provide this. Ladies and gentlemen, I don't have much time, so I will jump straight to the last discussion which I wanted to have, and that is on how do we finance this highest standard of attainable healthcare. We have a few options which we have looked at as a country and perhaps as a people. Sometime in 2004, we went on to Parliament adopted a piece of legislation, the National Social Health Insurance Fund, which unfortunately the then President Kibaki refused to assent. The argument was it was not well thought out, the country was not ready, and it faced a lot of opposition from the private sector. In order for many people to be able to benefit from the highest attainable health standard and services, then perhaps we need to find a way of providing this. I'm not sure our NHIF as it currently stands today probably provides as much as we need. I learned somewhere that there is a typically different way in which a poor person and a well-to-do person approach the matter of health. If you are rich, you get unwell today, you wake up tomorrow and you go to the hospital. A poor person will start by waiting to see if the disease will go away. If it doesn't, then he goes to the kiosk next door and buys a few Panadols or Piritons and takes those. Usually some of them are expired or no longer working. They'll probably get some outdated, expired medicine from the next kiosk and use it. Maybe it will not work. They will probably call their mother back at home and ask, ni miti gani ile tulikuwa tunakunywa wakati kuna shida? And that's what they would probably do. So going to the hospital, especially in rural areas where you have to travel long distances, is a last resort. It means selling your goat or sheep or cow in order to get the money to go to the hospital. Now, how do we marry these two people and be able to provide for them adequate health care? Ladies and gentlemen, unfortunately, I have various proposals. I don't have answers which I can tell you this is a sure way of doing it. I've said one of them is what the government has tried to do, introduce free maternity. Of course, it has its challenges in terms of the numbers, in terms of the infrastructure, the equipment, the personnel, and a few other things. But I think it's a good idea going forward. Number two was the scrapping of user fees in various health dispensaries and health centers. Again, has gone a long way towards that, but still probably not enough. Why? Because many hospitals are still charging some fees for you to be able to see a doctor or buy medicine or get an x-ray, among other things. And then the last thing is cost sharing in most hospitals. It is still a fact that if you come to Kenyatta, you don't just get treated and you go home. You'll have to part with something. And therefore, how do we make sure that people who can't afford to go to hospital actually manage to work this out? One way in which we have tried to do that is to have a waiver system which says that if you can't afford this completely, then the government or the hospital will waive your fees. We usually don't call it a waiver, we call it credit, which means it's a debt hanging over your head. Someday you might be required to pay it. But in essence, many people won't be able to pay it, and therefore, essentially, it's a waiver. But again, this is, it's bogged down by the bureaucracy that surrounds getting onto the list of a person whose fee has been waived or has been given credit. And therefore, I'm saying these are options, but they are not foolproof as yet. My time is up. I beg to leave at that. We perhaps can take a few more comments during the question and answer.